All right. I've just been informed that we're live here. So my name is Kirk Hughes. I'm the Education Director for the Minnesota Poison Control System. I'd like to thank the Minnesota Farm Bureau for allowing us to participate in this important subject about opioid crisis in rural America. More specifically, the people helping me today, Jody and Kristen, doing an awesome job bringing you this technology. A couple of housekeeping things. If you are calling in, unfortunately, because of the technology, you will not be able to ask a question. If you are tuned in and actually viewing this, please hold your questions till the end. And if you go to either the top or the bottom of your screen, there's kind of a toolbar, and it says Q&A. If you want to go ahead and ask a question as I'm presenting here through the next hour, towards the end, I will go ahead and archive those, and I will try and answer them in the order that they come. So feel free to ask a question as we go. But I'll try and answer as many as I can with the time that we have left. So having said that, it's a pleasure to be with you from the comfort of my own office. And it looks like this is a great technology. So at the end, I'll have a slide that has my contact information, and feel free to contact me with any questions you have regarding the subject or anything else. So with that, we'll get started. Hopefully. Uh-oh. Or not. I thought it was in the mode to share. There we go. All right. So just a little public service announcement. I know this has nothing to do with opioids, but it is a public service announcement. We at the Poison Center do celebrate International Extraterrestrial Abduction Day. So as a public service announcement, if you don't want to go ahead and have these in your field or possibly be taken unbeknownst to you, you might want to go ahead and have your family wear these on March 20th. So with that, we'll go ahead and get on with a more serious subject here. So the Minnesota Poison Control System is part of the American Association of Poison Control Centers. We are one of 55 poison centers accredited by that institute, which basically means that we are 24/7. We have staff that has special national certifications. The staff at the Minnesota Poison Control System is pharmacists. So in addition to all the other things that we do as far as your kid getting into something, maybe yourself or your husband or your loved one, a significant other, gets sprayed with a chemical as they're in the field, we can answer all those questions. We can also answer medication questions too. So if your primary pharmacist or your prescribing doctor is not available, you got something new, you want to know about drug interactions, our specialists can go ahead and answer those questions for you because they are also pharmacists. And it is a free service to you guys. It's confidential. It's like talking to your doctor. We are HIPAA compliant. There's no charge, and we are 24/7. We're always open. I just updated the slide today to show that we have, in 2017, this is how many calls the Minnesota Poison Control System took. And so 46,000 calls just from Minnesota only. 41%, as you would imagine, were from kids. And then 28% were actually from healthcare providers. So here's kind of the deal. Toxicology is the area of medicine that is most changing. There's only 200 board-certified medical toxicologists in the United States. It is the most specialized area of medicine. And because I know how to do two things. I know how to breathe, and I know toxicology. There is a SpongeBob episode, if any of your kids watch it, where SpongeBob only knew fine dining and breathing. Well, that's kind of like me and my staff. We know toxicology and we know breathing. We're very good at it. So much to the point where a lot of physicians will go in the back room and call us and actually remotely manage the overdose, make suggestions, or make sure they're giving the most appropriate evidence-based treatment that is currently out there. And then 93% of the cases where people called from their homes about their loved one, their child, whatever, we're able to safely manage them at home. That actually saved the state of Minnesota $35 million a couple of years ago in a study from needless emergency room visits. So I know a lot of farmers don't like to go to the emergency room unless they're on their deathbed. But this is a good way for you to go ahead and call in, and we can keep you at home a vast majority of the time just because of our advanced knowledge of toxicology. So I just want to let you know about our staff. We talked about this, and actually that should say the Minnesota Poison Control System. But we are staffed with pharmacists that have specialties in poison, the poison area and toxicology. So this is the kind of sobering slide to begin things, and this is the cost of drug abuse where it's gotten our kids. So 4 kids in Chanhassen, Minnesota, were unable to graduate in 2016 because of overdoses. 2 were attributed to heroin, which is right up the subject that we're talking about today. One of them was possibly a synthetic hallucinogen, and then another one is where synthetic cannabinoid, or a fancy word for synthetic pot, was considered to be a contributing factor in the death. So as you can see, this is a high cost, and there's probably everybody who's listening or watching who's been touched by this by either an immediate family member or an extended family member. I know it has in my family, and so I can certainly speak to this also. So a little slide, we want to kind of establish the problem, which we know is out there, but the numbers are more staggering than I would have imagined before I did the research on this. So back in 2015, in the United States, there were 52,000 people, over 52,000 people who died from overdoses. A vast majority of these were opioids. You can see the traffic accident there. I don't like reading off slides, but was significantly less. And so since 2009, overdoses have killed more people than motor vehicle crashes in the United States. I can tell you, looking at the data in Minnesota, that is the same case also. And now you can see the guns there, as this is kind of a hot topic. I know whatever about this, just throwing it in there, just showing the absolute overwhelming cost of overdoses to our society today. Now, fast forward to 2016, this data came out fairly recently. As you know, it takes a little while for them to get updated numbers and to vet those numbers. But 64,000, this is not a problem that's going away, which is no surprise to anybody. Some more kind of busy slides, and these aren't my favorite, but I think that these visuals represent a great, well, just a great visual to go ahead and see what the cost of this is. And so if you can, this is a good slide at the top, the 7-county metro versus greater Minnesota. As you can see there, statewide, there were 637 overdose deaths from 2000 to 2016. Greater Minnesota, there was 236, and the 7 metro county were 400. Now, last year, those numbers were reversed. And then if you look at the lower chart here, we can see that opioids decreased outstate a little bit, but meth and psychostimulants increased rurally. So there's still a lot of people dying, but the metro actually outshined or had unfortunate outcomes a vast majority of the time in 2016. 2015 was different. We were more rural deaths. So, and then you can see this bottom chart here. This came from the Minnesota Department of Minnesota of Health, or Department of Health from MDH. And this came through their opioid dashboard, which is an excellent resource, and I'll have that on the end slide, about how opioid deaths have increased 18% from 2015. So pretty staggering. It's not going down, despite having an antidote out there that can help or reduce the amount of deaths. This is something called the Prescription Monitoring Program. It's called the PMP. Now, prior to July 1st of 2017, people that prescribed scheduled types of prescriptions, and being scheduled means that it has a high potential for addictiveness. So for example, Schedule 1 would be heroin, something that has no medicinal use. Schedule 2 is something like oxycodone, has a very high potential for addiction and abuse. And then Schedule 3, actually they made hydrocodone Schedule 2 also. But then you get into your codeines and all those other sorts of things. Well, as of July 1st of 2017, all prescribers were mandated to report. Why is this important? So the Prescription Monitoring Program was not developed to be punitive or to hunt down doctors who are maybe overprescribing opioids. It's to collect data such as this. And so now that all prescribers are on board, we can actually collect very solid data that's been vetted, and knowing that every prescriber who's prescribing this in the state will be recorded as far as for statistical purposes, and we'll be able to see trends better. Whereas prior to this date, only about half of the providers were voluntarily participated in this. So this is a great tool for us to go ahead and track trends and find out from a public health perspective where we can do the most good. Just another slide. What I really want to highlight there is on the left-hand side. So these are mortality is death. And so 2015, the more red it is, the more deaths there were in those areas. So look at 2005. Now look at 2014, how much more red there is. And so there's even more red if you look at the 2017 data, but just even in that brief 9-year period, you can see how many more deaths there have been and how it's really spread across the entire United States. And there's a lot of that area that's rural too, so which is part of the reason we're here today. All right, kind of another busy chart. I just kind of like the way it was laid out. I get bored with the traditional kinds of charts, but basically what this is you know, as much as we hear about opioid deaths in Minnesota and opioids in the news and that sort of thing in Minnesota, we are 45th as far as deaths go. So we're way down there. We're in the bottom, obviously, way at the bottom there. North Dakota and South Dakota are even below us. So just imagine other regions such as the Appalachian Mountain region, which is in West Virginia, the Northeast, where there's New Hampshire, Rhode Island, and then north central Ohio, where there's a lot of overdose deaths. There are some EMS and fire entities and police entities that respond to towns in central northern Ohio where they're using 10 to 40 doses of Narcan in a shift. Absolutely unbelievable how it's really gripped that particular area. So, and that's Heartland USA. So more statistics will be done with these soon. So 3.5 million prescriptions for opioids in 2016, that's down. So part of the holistic way to tackle this is to go ahead and educate doctors and not overprescribe opioids. There is still a role for them, but it's just going ahead and letting people know that, you know, so for example, when I was 9 years active military, and halfway through, I got a kidney stone, which was the worst pain I've ever felt in my life. I went to Balboa Naval Hospital in San Diego, and I got a shot of Demerol, which took my pain away, and I didn't like the way that felt. It's the worst pain I ever felt in my life. But upon discharge, they gave me 90 Percocet. How many did I use? I used about 5. The rest sat in my cabinet for other people to potentially go in and use, or for me to use on a rainy day if my leg really hurt me and I needed to go out and do something. So, you know, part of the reason is we have way too much of this out there. And so I thought this was interesting. This is data from the prescription monitoring program in Minnesota. And so these are the counties. The first 5 are the ones that have the most doctors prescribe the most opioids. So right there, you can kind of see the cluster, right? And there again, this isn't made to be punitive or judgmental. It's made to kind of see where we can help target public health messaging and that sort of thing. Now, the lowest in the state, Jackson, Dodge, Nobles, and Olmsted. So way down there in the south in Houston. And so I just thought this was kind of interesting. So you can kind of take that. If you're in the ones in the lower ones and you got some pain, you're probably not get opioids. If you're up in the Wadena area where my brother lives, you're probably more apt to go ahead and get them. So Governor Dayton came out within the last couple of weeks and outlined Minnesota giving some money and going ahead and outlining some of the areas that need to be improved upon. And we kind of touched upon these. So mandatory prescriber education. This would be doctor education. In our society, doctors tend to walk on water, and they do amazing things, and they're very well educated, but they're traditionally hard to go ahead and get messages to. And so what we're doing is we're using other physicians and statistics from the prescription monitoring program to go ahead and help them be more mindful of how to go ahead and appropriately prescribe opioids. And there's a lot of them that may not do a lot of that. And so when they do, they're not really sure. And so it's physician education. And then some prescribing guidelines to help them with that is the number 2. Number 3 is eliminating pill mills. So kind of like puppy mills, there's a lot of pill mills out there. Having law enforcement identify those, mitigate those, so we're not putting stuff out into the street and having less of them. Prescription drug monitoring program, we've talked about that already. Increased access to Narcan or Naloxone. Narcan is actually the trade name for Naloxone. Naloxone is the reversal agent for if somebody's not breathing but still has a heartbeat, to go ahead and give them and potentially go ahead and wake them up so that they breathe appropriately and don't go into cardiac arrest. And then the availability of opioid use disorder treatment. So basically getting more people access points to get treatment. It's woefully inadequate with the number of opiate addicts that we have in the United States and in Minnesota, and trying to find out ways that we can go ahead and allow more treatment programs and that sort of thing so we can get more people help and get them back to being productive people. This is kind of a busy slide, I know, but here's one of the areas, as we just described, where we do doctor education. So this blue area here in the big circle is where people got their opioids. Free from a friend, 53%, or a relative. Well, out of those 53%, 84% of them obtained them from one doctor. So just like anything else, there's a few bad eggs who need a little additional education to go ahead and let them know that this is an acceptable kind of behavior. And so that's why we're educating doctors about this stuff. So a toxidrome. I don't want to get too much into the medical aspect of things and keep it pretty simple. I kind of like the KISS method. Keep it simple, Sam. But use a different word at the end, but we'll be PC here. So the toxidromes. A toxidrome is basically a term used for the different types of symptoms that we can see for a particular class of medications. And so an opioid is a class of medications. That can be anything from illegal opioids, such as heroin, butyfentanyl, those sorts of things, or ones that are prescribed, such as oxycodone, hydrocodone, fentanyl, Dilaudid, those sorts of things. And then also something called novel synthetic opioids. These are opioids that have never been brought as a authorized medication through the FDA, but they were researched and they were shoved away somewhere because they either didn't last long enough, they lasted too short, they weren't powerful enough, they were too powerful, and they wouldn't have passed the FDA's rigid type of clinical trials. And so they were just shelved, and a lot of these drug cartels are accessing those because they're hard to litigate against. And we'll talk about that in a little bit. So when you have an opioid toxidrome, if somebody's used too many opioids, you are going to see these things. They're going to have pinpoint pupils, and they're going to have reduced breathing or not breathing, whether that's carfentanyl, whether that's your Vicodin or Percocet, which also has acetaminophen in it, or whether that's your Dilaudid kind of stuff. So they're all going to have the same effect. Pinpoint pupils, decreased breathing, or they're not going to be breathing. When they stop breathing, you have about 3 to 7 minutes before their heart stops. Once their heart stops and you give them naloxone, that's not going to reverse it. You can't bring them back to life after that. So it's really that window of time between when they stop breathing, that 3 to 7 minutes before their heart doesn't get enough oxygen, where you can actually go ahead and bump off the opioid off the receptor with the naloxone or Narcan and wake them back up before they go into cardiac arrest. Because once you're in cardiac arrest, then we have to do the traditional medications and that sort of thing, and there's no guarantee that the reversal agent, the naloxone or Narcan, will work. All right, kind of a weird slide. I'm usually in person when I do this. I'll do my best. So this is my beautiful wife here on the left that says heroin ligand. It's just a fancy word for something that goes to a receptor. So I want to teach you some really basic pharmacology here so you get a better understanding of how opioids work and how the antidote naloxone works too. So, and I'm the opioid receptor. So imagine me, I'm here, standing here with my arms open. I'm an opioid receptor in the brain, and I'm just waiting for somebody to come along to grab. Now, these opioid receptors have specific shapes so that any opioid will come to me and I will hug it and then feel really high or feel good or feel pain relief, whatever I'm using it for. Or something that's similarly shaped like naloxone will come along and it will bump that heroin off or that opioid off, and I will hug that, and it will stop that feeling from happening, and I'll wake up and start breathing. Hopefully that makes sense. So let's just say that I'm in the room by myself. My wife walks into work here. Hey, Kirk, how's it going? And we've been married for 24 years and been going out longer than that. And, I give her a big hug. So she's heroin, and I'm the opioid receptor, and I give her a hug and I feel really, really good, right? Kind of like a drug to me. Still feel good after 24 years, that kind of thing. So I'm hugging her. Also, one of my friends comes in, they knock on the door. Hey, Kirk, somebody I haven't seen for a while, and they represent one Narcan. So one small dose of Narcan. They come in and I just let my wife go and I give them a hug. I, as the receptor, would prefer to hug that Narcan more than my wife. All right. And she knows I use this, so we're all good there. But so that's kind of the impetus behind this. Now, let's say that I'm standing here and I'm the opioid receptor and my arms are out here. I'm kind of like waiting for a hug. And Nicole Kidman walks in. Now, I think Nicole Kidman's pretty hot, right? And if she ever knocked on my door to my office, I'm going to give her a big hug and I'm going to hold on to her and I'm going to feel really good, obviously with her permission, and go ahead and give her a big hug and say, oh, this is great, and she represents fentanyl. So I'm hugging her. And let's say a whole bunch of my firefighter buddies come down. Hey, we just dropped somebody off at the ER. We came down to see you. And there's about 6 of them, right? Firefighters are pretty burly guys. And they walk in, they're like, hey, Kirk, we want to give you a hug. And I'm like, no, I'm hugging Nicole Kidman. I kind of like her. And they're like, no. And they tear her off of me and I go hug them. They represent the equivalent of, like, for example, 4 to 6 doses of Narcan. It takes more Narcan or naloxone to bump off fentanyl than it does heroin. And that's going to play an important part here. So keep that in mind. I hope I made that clear. So that's kind of basically how the opioid receptors work in our body. This is naloxone or Narcan. So in the upper left-hand corner is a kit. And this is a kit that in the state of Minnesota now, anybody who's police, fire, EMS, who are not at the paramedic level, because previously only paramedics or above could give this medication to people if they overdosed. The traditional way that I would as a basic life support firefighter is I'd put in their oral airway and I would bag them manually one breath every 5 to 7 seconds until the paramedics got there and gave them this medication. Now, this medication goes up the nose. This is 2 milligrams, all right, in 2 milliliters of fluid. And basically what you do is you assemble this thing and you put it up their nose and you press half of it up one nostril and half up the other nostril to the person that's unresponsive. So police, fire, and EMS at the basic level, the EMTs and below, can carry this if their agencies decide that this is the route they want to go. And so this is really beneficial for sheriffs outstate in rural environments where their response times for their volunteer paramedics and volunteer medic services to get out there can be literally minutes, if not up to an hour. And so, of course, the law enforcement, the sheriffs can get there quicker and get there within that 3 to 7 minutes before they go into cardiac arrest, put this up their nose, and theoretically they should be able to wake up. Now, 2 milligrams is a lot. To put this in perspective, there was a big study done amongst the heroin using population in San Francisco years back. When they gave people naloxone, 0.1 milligrams, all right, very, very low amount, 0.1 milligrams, they woke up and totally reversed that respiratory depression or that not breathing they experienced. Now, with some of these other things like we just talked about, like the fentanyl, it gives that bigger hug and you need more Narcan. And so this is where the 2 milligrams comes in. We don't have a choice. We can only give 2 intranasally. Now, sometimes that puts people into withdrawal. We'll talk about withdrawal in a little bit, but they don't like going to withdrawal. Sometimes they can get very nasty, call you bad words, and once in a while go ahead and get combative with you, which is why I'm retired from Brooklyn Park Fire now, one of my larger departments. I'm on a couple of different smaller departments now, but we were able to give naloxone via this route intranasally to people. And I gave it one time and woke somebody up, and he got really upset, and we had to leave the apartment, and he wanted to called me some not so nice words and tell me to give him his effing $20 that I ruined his high from because I reversed him, and he wasn't very happy about that. So law enforcement came and they took care of him, and he rode the lightning twice, and you know, kind of thing, got tased and wasn't very happy about that. But sometimes we can put him to withdrawal, but it's better than them dying. All right. The other one in the upper right-hand corner is a 4 milligram intranasal. There are some EMS entities and law enforcement entities up in the Duluth area who are using this. And, you know, sometimes this can be too much too. But the flip side of the coin is I've actually seen 10 milligrams of Narcan given where they didn't wake up and it was an opioid. That's because at the receptor, it was one of those ones that were giving a giant hug and it was not letting go until a whole bunch of friends or a whole bunch of Narcan came, 10 milligrams in this case. And I've actually heard and verified 12 milligrams reversing somebody once. So if anybody's out there and are familiar with this, those are huge doses. The lower left-hand corner are auto injectors. These things will talk to you. They're very, very expensive, but you can put them in the outer aspect of your thigh, just like an EpiPen, and they will go ahead and inject with the yellow one, 0.4 milligrams of Narcan, and with the blue one there, 2 milligrams of naloxone, and they will talk to you. It's a single use. Some insurance companies are covering these for people that have been on painkillers for like 20, 30 years. Our body develops a tolerance to these. And so somebody who maybe takes 30 milligrams of oxycodone for the first time, it's going to knock them on their butt and they're going to be really sedate and kind of feel high. Whereas somebody who's been on it for years and years, 30 milligrams isn't going to touch their pain, their chronic back pain or whatever. So they're up to many, many more milligrams. What happens is when they're on so much after so many years, if you accidentally double up, that can put you over the edge where you stop breathing and then a family member would have to give you these. So that's why these auto injectors have been provided through some insurance companies to people that are on chronic opioid therapy. Then the other one is actually a Rummler kit. And the Rummler kit is this, it comes in a blue pouch and it's everything in the lower right-hand corner. So it comes with 2 syringes, 2 vials of Narcan, which is 0.4 milligrams, all right? And actually they're adding a 3rd vial because they've actually been people who have taken this and given them 2 vials and it didn't work and they need to give a 3rd vial and it still didn't work. So this is provided to anybody who asks. The Rummler Foundation was actually started by Steve Rummler's sister. Steve Rummler was a gentleman who used heroin. He was with his buddy. They wound up doing too much. He stopped breathing. His buddy wanted to call 911 so they didn't pass and have a bad outcome. But unfortunately, his buddy had a bunch of heroin out and paraphernalia. Well, he didn't want to get busted by the cops, so he quick put everything away so the cops wouldn't bust him, then called 911. Remember, you only have a 3 to 7 minute window before you go into cardiac arrest and you can't reverse it with a naloxone. And so his buddy wound up dying. Steve Rummler died. And so his sister started investigating this and said, hey, there's a medication called naloxone out there. that really doesn't hurt anybody if you give it to them if they don't need it. So for those of you out there wondering why only paramedics could give it before, it was because it was a prescription medication. It is now in the state of Minnesota, I think we're the 23rd state, to change your Good Samaritan law to say basically that, you know what, even if you have your heroin out, you can call 911, don't run, call 911 so that you can get help there. Or you can go to your local hospital and ask for a Rummler kit. I know at Hennepin County Medical Center, Hennepin Healthcare, sorry, we have a new title now, Hennepin Healthcare, you can come to our ER and just say, hey, I need a Rummler kit. We will give you this kit in the lower right-hand corner free of charge, so that hopefully that if somebody does some heroin that's a little more potent than they're used to, they can live another day to hopefully go to recovery. So that's the impetus behind this. So those are the forms of Narcan or Naloxone that we have out there in the communities today. So how does this all start? Well, Vicodin, we've all probably gotten Vicodin before. Percocet, so Vicodin is hydrocodone and Tylenol, and Percocet is oxycodone and Tylenol. Then there's OxyContin. OxyContin is a long-acting form of oxycodone. These are highly sought after in the community. So what happens is a lot of people start, they will for maybe got in a car accident and their doctor said take, 1 to 2 of these every 4 to 6 hours until they're gone. And maybe like my Navy doctor did, they prescribed me 90 of them. Well, I took that. Maybe I've got the genetic wiring to like the way that feeling feels. I personally don't. I know for a fact. I prefer my Captain Morgan actually, and I can titrate that. But I don't like that feeling. But some people like that feeling, and so or they just are genetically or chemically made up to go ahead and become more prone to addiction, and so now they're addicted to this stuff. And so people who are doing this are taking 10 to 40 of these pills a day, 10 to 40. All right. Now, the old school way was, now there's no way your doctor is going to prescribe you that many because you gain that tolerance. You need more and more and more to prevent withdrawal. Now, withdrawal is not like threatening. We'll talk about that in a little bit. But people do not like to withdraw. It feels absolutely horrible. I have spoken to an addict and asked him if he could describe to me in simplistic terms what withdrawal felt like to him. He asked me if I had ever had the bad flu, the real flu, not this other kind of norovirus or kind of whatever. And I said, yeah, a couple of years ago, I actually had the flu. I was sick for 3 days, really sick, to the point where I had to call into work, which never happens. And so I said, yeah, I'm familiar with it. I felt like I was on my deathbed for 3 days. And he says, well, think about that times 100. And I'm like, ooh, times 100. I mean, even if it's times 2, that's horrible if you've had the real flu. And so he goes, and you know what's coming. And he goes, you need to get well. And this is what they say when they're going to withdrawal. This is the term they use on the street, is they need to get well. They need to go ahead and get something in their system, another opioid or something that hugs that receptor to prevent them from going to withdrawal. And so they'll take this. Now, obviously, you don't have access to 10 to 40 Percocet a day for 30 to 90 days. So they start doing ER hopping. They'll walk into an ER, usually in a more remote area where the ER physicians were typically naive to this, not anymore, but in the recent past. And they'd say, I got a really bad migraine. If you've had a migraine, you know how bad they are. And physicians know this too. Or I've got really bad tooth pain. I haven't seen the dentist in a few years. My tooth really hurts. Those are some of the reasons that more naive ER clinicians or providers would go ahead and give you a couple to get you through and to prevent withdrawal. But it was a constant thing. Your focus in life is is to go ahead and constantly get this so you don't go into withdrawal. This is your sole focus in life. You care about nothing else. Now, if you can't go ahead and get 10 to 40 a day, this is where the drug cartels went in and said, hey, you know what? Let's go ahead and start bringing in heroin to the Minneapolis Twin Cities area and set up shop here. The reason being is they brought up heroin. It was very cheap, $5 to $7 a hit, and it was very pure. So people that like this feeling, they said, hey, you can't get your Percocet for $5. We'll go ahead and sell you some heroin. They're like, well, I don't want to start jacking a needle, because there's a big difference between people popping pills in their minds and being a drug addict and actually shooting themselves with a needle, because then now you're a hardcore addict, right? Well, so you can actually snort it and get pretty high. People that tried heroin for the first time, there's a reason that people get addicted within the first or second time they use it, because it feels so incredibly good. So if you like the way that the Vicodin and the Percocet made you feel, the heroin made you feel really good, and it was cheap. And so what they did is they started going to heroin, and they got a bunch of people hooked, all right? Once you got them hooked, then you start going ahead and reducing the amount of heroin that's in there to go ahead and make more money off of this. We'll talk about that in a minute, to reduce its potency, or replace it with something else that will give that receptor a hug, but not as good a hug, so you don't get as high, but it prevents you from going to withdrawal. And they jack up the price because, let's face it, it's a business. The cartels run a very tight business, though it's very, very unethical. This is how many pain relieving pills are out there in the community today. There is enough for every American adult to have a bottle of Percocet or Vicodin in America today. That's how many there are. So some of the strategies to getting rid of these is to go ahead and have drug disposal programs. And you need to check with your individual community. I know we work with a group called Partnership for Change in Hennepin County, the Poison Center does. And the Hennepin County Sheriffs have put out 12 different drug disposal bins. Some are open 24/7. Some are in the lobbies when they're only open when the police lobby is open, where you can put any kind of prescription med in there without fear of being, prosecuted for having possession of them. Maybe you had somebody in your family die, the elderly, right? They were a depression era person. They kept every med they had, so they can do pill sharing. A lot of seniors do that. And so, the caregiver, such as myself, would go in there and clean them all out. You can put all those stuff in there. Each county has a different, there's not a statewide kind of impetus behind this yet, other than to encourage this. And so just check with your local community leaders or your law enforcement to find out where you can get rid of your unused prescription medications to effectively get them out of the potential hands of people that can abuse them. They will break into your house for these, and they know that too. So that's happened a few times throughout the history of Minnesota here. So this is heroin. Interesting, a little history about heroin is it was actually marketed as a non-addictive morphine substitute for cough syrup in children. Yes, they used to give children at the late 1800s, early 1900s morphine as a cough suppressant, and it works very well. My now 21-year-old daughter, when she was 5, had whooping cough. Back before this had even emerged, nobody believed that she had whooping cough because she was vaccinated for it. Well, there are actually 5 kids in the cul-de-sac where we lived at that time in Brooklyn Park, Minnesota, that got it. And they tested her, and they're like, well, we don't know how this can happen, but it did. She coughed so much, it was 24/7. The cough syrups didn't help. They finally gave her a cough syrup with codeine in it and gave her a little relief. It was gut-wrenching to listen to. And so the opiates work to help suppress coughs, in addition to some of the pain that comes from that too. So, but interesting, they gave heroin as a non-addictive substitute. Well, we know that's not the case anymore, and so this is being primarily used. So this is another potent analgesic or pain reliever out there. It's fentanyl. This is a fentanyl patch. So other things come in patches too. Now these things look a little, they're clear and they're really thin, and they don't look like they contain much medication. Well, they actually do. So this is designed to go on the skin. So what you do is you basically, roll up your sleeve, you put it on your skin, and within 12 hours, it will reach its peak effect and relieve you of the pain that you're having. All right. Now keep in mind, this is designed to go through the skin, and it takes 12 hours to reach its peak. All right. Now, works very good for severe pain. What happens is this patch, if you take it off, so let's say you're a caregiver for somebody with end-stage cancer. Maybe they're doing hospice in their home to keep them comfortable. You take this thing off and you throw it in the garbage can. Well, guess what? People that abuse this stuff know that used fentanyl patches still contain 30 to 62% of fentanyl in there. The reason is, it's simple science. You put it on your skin, and it's packed with so much medication, even though it doesn't look like it is. It literally goes from high concentration and pushes through your skin until it equalizes. And then that leaves still a lot of medication within that patch. So if you grab these out of the garbage, or you work at a nursing home where somebody's on these, and you take it off of them and don't flush it like federal guidelines say you should, and you cut it up into 4 or 6 pieces and roll it up, you can sell it on the street and supplement your income very well. So we need to get rid of these things. They need to be, the technical answer is flushing down the toilet from the White House. And this has been the same White House, no matter who's been in here. These are federal standards. Some people don't like doing it. Mix it with something where it's unusable. But the bottom line is these, even used, can be still pretty potent. Now, another thing they're doing is they are contaminating intentionally your heroin with fentanyl or other types of fentanyl. So if you're on a fentanyl, these are little tweaks on the molecule that cause different things. So you can actually buy, these are test strips off Amazon that you can go to Amazon. If you happen to be a heroin user and you don't want to get the bad fentanyl because that can kill you, you can actually test your heroin. And so to see if it's got fentanyl in it. Now, keep in mind, if you look down at towards the bottom of the slide, a negative result does not mean a sample is safe to consume. It doesn't say safe. It's obviously done by somebody who doesn't speak English very well. And no drug use is 100% safe. So this does not measure carfentanyl, fentanyl, butyfentanyl, all these other types of fentanyls that are not pure fentanyl. And so if you use that, those are much more dangerous, and you may wind up dying from a respiratory arrest from using that. So why do they do this? Here's why. It's all about the Benjamins, all right? So heroin costs about $35,000 per kilogram. If you cut that down into street level potency, you can make about $500,000 off that paltry $35,000 investment, all right? So if you got an extra 35K to throw around and you want to make about $500,000 and you want to get involved with that group, this is the way to do it. Now, if you go ahead and now that you got people hooked, right, and you sold it cheap, now you're jacking up the price. Now you're going ahead and putting stuff in there that doesn't get them as high. Your customers aren't happy. But do your customers have to be happy? No, because you walk up to your drug dealer and say, hey, man, your stuff sucks. It doesn't get me as high as it used to. Your drug dealer, well, you may not take that so nicely. You don't disrespect your drug dealer, and you might wind up with a gunshot wound or worse. So, you know, they live with it. At least it doesn't put them into withdrawal. So they kind of live with it, and that's why they use the fentanyl. Now look at fentanyl. $3,500 can net you $500,000 in profits. Big difference there, right? Huge profit margins. And so basically at some point in time, you add fentanyl, or if you're on a fentanyl or some these other things that have not been well studied into there that are easy to make and really exponentially make a lot more money from your initial investment. This is why they're doing it. Interestingly enough, and I've asked this question before and I've actually researched it now, the last time in the United States we had a heroin epidemic was post-Vietnam, or right at the end of the Vietnam War. They estimated that 10 to 20% of U.S. soldiers were addicted to heroin or opium while they were over there in country by the end of their tour. So then President Nixon declared a war on drugs, which is still going on and debating, arguably not been very effective. It was called Operation Golden Flow. Now, having been a sailor for 9 years, I can tell you that we had to be personally observed within 5 feet when we were doing our urinalysis samples. Some days we had the potential to be tested urinalysis-wise up to twice a day, depending on what the end of our social security number was and what the dice rolled. So what they did in this case, and this is the way they mitigated it, is they had a urine drug screen. That's what UDS means, urine drug screen, prior to leaving Vietnam. If your urine drug screen popped positive for opioids or heroin, guess what? You weren't going home. And so what they do is they put you in 5 to 7 days of a detoxification program. Now, they didn't well delineate what this meant. So remember we said withdrawal from opioids is not life-threatening, but you feel like you want to die? My suspicion, I can't verify this, and I'm going to look into it further as to how they did this, is they probably put them in a room and let them detox and have terrible, diarrhea, feeling like they had the flu 100 times worse than the real flu is, and that sort of thing for 5 to 7 days, and then got them off of it. What's interesting is the results were very, very efficient. After only a year, only 1% remained addicted. 1%. Only 5% relapsed within a year. If you look at other types of treatments that we're doing, such as, we'll get to it in a minute, but like methadone and suboxone, which are other types of treatments, their success rate is less than 10%. So I know it's not really apples to apples. It was a different deal. I mean, you couldn't go home until you got tested and got clean, which, they had a captive audience, so to speak, as the military usually does. But I think we can go ahead and look back at history and see what things worked in the past, maybe incorporate things that did work that are equitable in this type of situation we're experiencing today. Love history. So just more stats about gun deaths versus gun death, or heroin deaths versus gun deaths. This is 2015. And this is interesting too. Now, we always talk about marijuana being a gateway drug, or even alcohol. Well, this is a very large survey done on drug use and health. So these were people who actually use this stuff, who subscribe to all these numbers here. So, if you want to go ahead and educate the kiddos about, smoking marijuana as a gateway drug, well, you're 3 times more apt to go ahead and get addicted to heroin if you're already a recreational or chronic marijuana user. And so you can see the statistics there. I just thought it was interesting. And there again, these were by people who were self-reporting in this very, very large survey. Lots of you have probably seen this before. So we talked about central Ohio, central northern Ohio being a hotbed for heroin overdoses and opioid overdoses. 10 to 40 runs in a 24-hour period where they need to use Narcan because of overdoses. This was one of those. And you guys probably saw this in the news. In the back seat, in the picture on the left, is a little 18-month-old Billy. I don't know what his real name was, but he was there. His parents just scored some heroin. They drove around the corner, and they usually just, all they want to do is get it into them. They shot it up, and they were found like this. Luckily, some passerby saw them. Local law enforcement there does carry intranasal Narcan, and they gave them Narcan and woke them both up. Hopefully they both woke up realizing that their kid was in the back seat as a captive audience and got some help in rehab. It's very difficult to rehab from this, though. So these are what we call novel synthetic opioids. Basically what these are drugs that have been developed by pharmaceutical companies or universities as research opioids to try and find new drugs that are more effective. And as we stated earlier in the webinar here, these never met criteria to meet the stringent FDA clinical trials to bring them to market. But these are still out there. So what happens is, why do drug cartels use these? Well, what they do is they hire people to hack in to the pharmaceutical archives, the electronic archives, or the university archives. They get these chemical structures. They find somebody that we call an Uncle Fester. So if you remember Walt from Breaking Bad, he was a true chemist. They'll find these guys. They will find ways to go ahead and synthesize these and make them and then bring them to the street. They teach the street level dealers how to make it in a simplistic way using all kinds of nasty things like acetone, sulfuric acid to go ahead and make these synthetic opioids, and then they sell them. Why? Because if you're on the stand, let's say I was a drug dealer and I wanted to provide nutritional supplements to my people who are using it, and I'm on the street corner and I'm selling my nutritional supplements, and a bunch of people die. Well, they throw me in jail. They try and prosecute me for killing them for dealing drugs and causing their deaths because of the drugs that I sold them caused them to die, or my nutritional supplement. So I'm on the stand and they're like, well, what did you sell these people, Mr. Hughes? I sold them a nutritional supplement. What was in it? Well, only good things, you know, vitamins, minerals, you know, the things that wouldn't hurt them. Really? Well, isn't it a fact that the people who use your stuff died? Well, they might have died incidentally. And so then the defense attorney calls up a toxicologist and says, or the coroner. I also work as a death scene investigator for the Hennepin Medical Examiner's Office, and so I'm familiar with the process. And they grill the medical examiner and say, hey, what did they find in the blood? What kind of drugs of abuse? And he'll say, we didn't find anything. These things are so new or experimental, they're not in the databases of any of these machines that can read this, and so they can't detect them. And so the defense attorney say, well, Your Honor, it seems very obvious to me that they can't prove that what the nutritional supplement that my client sold to these people killed them, and I get to walk free. When in fact I had used a novel synthetic opioid that they were just unable to test because they didn't even know it existed because it was experimental, right? So that's the reason they use this. Now, these next few slides, I'm just going to show you. You don't need to remember the names. What we do need to remember is that there's a lot of these out there. So these are actually charts that come from the DEA, the Drug Enforcement Agency, and you can see third quarter of 2016 to fourth quarter. If you look on here, you see some of the same names on both sides of the fence, but they're in different orders. What they do is they continuously change up the synthetic novel opioids that are in these to avoid being prosecuted vigorously by law enforcement. And so they just change these around, and this is one quarter to the next of different things they found in there. Now, these will all cause pinpoint pupils and cause you to decrease your respirations or stop breathing. And naloxone will work on all these, sometimes in greater amounts. So here, this is a recent one. This just came out 2 weeks ago as an alert. So somebody's selling one of these where they put 1 drop of this synthetic novel opioid on a Tylenol, sold it to a law enforcement officer, and as 30 to 10,000 times more potent than morphine. Pretty serious. This is U-Boat. This is what they thought Prince died from initially. He actually didn't. He died of a fentanyl overdose. This is butyfentanyl, acetafentanyl, furanafentanyl. We call this FUF. We've actually seen this in Minnesota. We can now actually measure for this, both at the MEs and somewhat in-house here. And then carfentanyl. You guys have probably heard a lot about this. Now, carfentanyl is used only in veterinary medicine. 2 milligrams of carfentanyl will bring down this elephant here, all right? Some of the heroin has been contaminated with carfentanyl. Now, potency doesn't always equal lethality. Even though it's really dangerous, it's gotten a kind of, I wouldn't say a bad rap, but people simply assume that when you use carfentanyl, you're going to die. There's a higher potential because it's more potent, but there again, they're cutting it with some of the heroin for this, and so this has become a huge problem. So here's some myths about it. They're saying that it absorbs through the skin. This is a quote from a DEA person. It does not absorb through the skin. This is somebody who is well-intended, who wants to keep law enforcement safe, who doesn't understand pharmacokinetics. And so simply by wearing the gloves that we wear as police, fire, and EMS, this will go ahead and mitigate it from getting onto our skin. And even if it does, it's not going to appreciably absorb. Now, if it's really potent, and you accidentally touch your eye from some of the residue that's on it, or it's a windy day and there's this powder floating around, I'm going to put on a mask. But that's all I'm going to do. So the ACMT, which is shown at the bottom of the slide here, is the American College of Medical Toxicology. My boss, who's the medical director of the Poison Center and staff ER doc at Hennepin County Medical Center, sits on this and helped craft this. And basically it states that this carfentanyl does not absorb appreciably through the skin. And so we're trying to dispel that myth. We don't want anybody to be in contact with this, but it's not as absolutely horrible as they say it is, that if it touches you, you're going to die. It's simply not true. Withdrawal. We talked about this. Withdrawal is not life-threatening generally, all right? Now, withdrawal from alcohol, yes. Withdrawal from benzodiazepines, which is the family of medications that Valium and Xanax is in, is life-threatening. Withdrawal from opioids is not generally life-threatening, but they would rather die than go through it. This is the #1 reason people don't get off it, is because it's so horrible. Now, how do we go ahead and get off of it? This is what we call poor man's methadone. Methadone is one of the accepted treatment methods. It's not very effective, but the best that we have right now generally to treat withdrawal. So what methadone does is, remember, I'm that opioid receptor, right? And I've got my arms out with a big hug. This is kind of the equivalent to, I say my sister-in-law, so my ex-sister-in-law. So my brother was married to her before. I always kind of liked her. Obviously, they don't like each other very much anymore, would be an understatement. But she never did anything to me, and I still kind of like her. So she actually came to my hospital for another reason, and with her kid and blah, 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 with my nephew. And so I went ahead and I went up to the emergency room and I gave her a hug. Now, I gave her a hug, kind of a partial hug, right? So, you know, I'm not like super thrilled to hug her, but it's the right thing to do and I don't mind it. So it made me feel better about just giving her a hug and whatever. This is what these medications do, whether it's methadone, whether it's suboxone, or it's over-the-counter medication. It gives that receptor a hug. So if you Google online, let's say you're popping the pills, you're taking 30 to 40 a day, 10 to 40 a day. It's starting to affect your life. You're more crabby with the missus or the significant other. You're starting to miss work. You're starting to do that kind of stuff. And you go, how do I get over opiate addiction? Home remedies. This will pop up using the old anti-Hershey squirt medication, right? Called loperamide, otherwise known as Imodium AD. So our gut actually has opioid receptors that are a little different shape. That receptor is a little bit different shape. And when we take this medication, it actually gloms onto those receptors in our gut and prevents us from having the Hershey squirts. And that's how it works. Now, if you take a whole bunch of these, like boxes a day, it will go ahead and bleed over, and it's close enough in shape to go ahead and give me a hug, that opioid receptor on the CNS, but only a partial hug. Just enough to go ahead and prevent me from feeling the bad withdrawal, but not really getting me high, which is kind of the goal, right? The problem with this is if you go ahead and do this and you take boxes a day, which I've actually been on scenes where they have, it can cause a cardiac arrhythmia, all right? And so I'm not going to get into it, but it can basically, for all intents and purposes, cause a heart attack by misusing this. So you need to be educated about your drug abuse. You really need medical oversight to get off this stuff. And unfortunately, getting into these programs is tough. If you go into that opioid dashboard, the MDH opioid dashboard, actually within that, there are some resources on how to go ahead and get into a program, some ways to do that and that sort of thing. So it's kind of a one-stop shop, and I'll have that on my end slide. This is another one, kratom. Kratom is made to go ahead and give that receptor a partial hug so that you can get off of it but not get high anymore. It's totally natural, comes from a plant that's in the coffee family. The problem is it's what we call a polymorphic drug. It has different kinetics at different amounts. So if you take up to 5 grams, it acts like a stimulant. So it's kind of like drinking too much caffeine. You're like, woo, squirrel, you know, and you're kind of going like this, you know, and you're, wah, you know, you're just kind of buzzing along. Now, if you take it in 5 to 15 grams, it will actually give that opioid receptor that partial hug and prevent that withdrawal, but not get you significantly high. The problem is a lot of this kratom that's being ordered from overseas and manufactured here is not what it's always advertised to be. It's adulterated with other things. And from a personal perspective, me taking calls and managing overdoses from this, good things are not happening with this. So it does have some potential. It warrants further research and investigation to find which part of the kratom can actually help and take out the bad parts of it that are going to cause more bad things that cause ICU stays, which is what we see a lot when people use or abuse this. In Minnesota, kratom is currently legal with no restrictions. For a while, it was on a DEA emergency Schedule 1, but they've rescinded that about 1.5 years ago. So you can actually order this, and there's no legal consequences for it at this point. I would highly advise against this, though. Then there's Minnesota treatment. There's methadone clinics. There's only 15 clinics statewide. So, and it's very stringent as far as to be a doctor to go ahead and be able to prescribe this. You have to get a special number from the DEA and that sort of thing. The other one is suboxone. Suboxone can be dispensed by a lot more doctors. When I wrote this, there were 278 certified. There's much more than that now. We're trying to get more. And basically what both these medications do is give that partial hug without getting them high. Can you still overdose on it? Yes, you can. Methadone develops a tolerance. So if you went to jail because of drug-related things and you were on methadone and you went up to 120 milligrams and you get out after 3 to 6 months and you go back to 120 milligrams, you're going to die of respiratory arrest. All right. So you got to start back in. So, and it is abusable, but much less abusable than other types of traditional opioids. Then there's the old homeopathic way, right? And so a lot of companies are preying upon people who don't really want to go to treatment, who want to get off this stuff and try products that seem fairly safe. So I just put up some of these products, and specifically the reason I chose these were because these were 3 of the companies that made these products that the FDA sent warning letters to, warning them against advertising this will prevent or help you with opioid withdrawal. Basically what's in all these are vitamins and minerals and herbs, which may help with nutritional things if you're not eating because you're going to withdrawal, that kind of stuff. That's about it. They do not cure. They do not go on to that receptor and give it any kind of a hug whatsoever, which is what's necessary to prevent withdrawal. All right. So all it is a nutritional supplement, and that's why the FDA sent warning letters to these manufacturers of these products. Here's some more disturbing trends. So this is very recent, as you can see the dates here. Like I said, I don't like to read slides. We have a good relationship with the chief of EMS down in Northfield, and so they actually brought to our attention. So this pill here on the upper left is actually 30 milligrams of oxycodone. We know that, and I mean, every prescription medication has a unique alphanumeric code on it, so that can be appropriately identified. Now, the stuff on the right, the stuff on the left is a legitimate 30 milligram oxycodone. The stuff on the right was stuff that was actually confiscated by law enforcement down in the Northfield area, and they were tested at the BCA lab and were confirmed to have carfentanyl and cocaine in them. So there again, just because you're getting your pills from somebody doesn't always, so remember, cocaine is one of those things that amps you up, right? It causes you to go ahead and get jittery and you kind of have lots of energy and you're kind of looking around, whereas opioids bring you down, all right? So somebody said, you know, they come in and they're overdosing. We get people all the time that said, well, I just did heroin. Well, it's contaminated with cocaine, or vice versa. So these are pills that were actually contaminated with carfentanyl. This is actually what Prince died from. They were making Percocet tablets, allegedly, at the Purple Palace or Paisley Palace, whatever it's called, and somebody was adding fentanyl to them. They've actually verified this. And, you know, they were pill pressing him into these pills. So whether he had knowledge of that, we don't know, but it was adulterated Percocet tablets. It was adulterated fentanyl is what killed Prince, actually. So a lot of this stuff is not what's advertised. So buyer beware. Some more trends. So there again, this comes out of Montgomery County in Ohio, where Dayton is, where they have lots of opioid problems. So in recent seizures, 10% of the cocaine sampled in the Montgomery County area in Ohio contained cocaine and carfentanyl. All right. So you think you're going to go ahead and get some heroin, and it's actually got, or cocaine, and it's actually got carfentanyl in it. So there again, cocaine is an upper, carfentanyl is a downer, and carfentanyl can be very dangerous, can give really big hugs and take large amounts of Narcan to reverse it, and also cause decrease in respirations very quickly because of its potency. So with that, I would like to thank you. Thought it was kind of cute. Sorry, not meant to be offensive, but kind of cute. Thank you all for listening to us. We greatly appreciate it. You are welcome to call 1-800-222-1222 at any point in time if you have questions, you know, that sort of thing. Whether it's pesticides, whether it's medications, as you now know, because we have pharmacists staffing the phones, or whether it's about opioids or questions about that, it does not have to be an emergency to call. Please call us. Please utilize us. And the other thing is, if you want to learn more about this, in the upper right-hand corner, there is a little information about how to go ahead and get some training. You don't have to be an EMT to do this. This is pretty basic stuff. You can go onto our website at training.mnpoison.org, or just go to www.mnpoison.org, go under training and go online, and you can go ahead and take these modules and become more educated about it. It kind of talks about the Poison Center and the services we provide. There's also a section on Narcan or Naloxone if you want to learn more about it, and I didn't adequately discuss it here, or you just want to learn it in a different way. Please take this. It's free of charge. We're nonprofit. We don't sell any of your information to anybody else. We're not tracking it. We just simply want to go ahead and provide some information about the Poison Center and about Naloxone modules within that to do that. So the other resource we have is actually, if you Google search, or Bing, I don't like Bing, but if you Google search, and I have no financial interest in Google, MDH Opioid Dashboard, that will provide you with lots of resources. Some of the charts that I had in there are from that. There are other things such as where to get help. You can explore there. It's a good resource for personal, individual, advancing your knowledge, finding out what's happening in your area. That's where I found out where prescribing habits were highest and lowest by county there. Really, really good resource. It's a one-stop shop. It's made for citizens, for healthcare providers, for police, fire, law enforcement, or police, fire, and EMS to go ahead and access. And there again, it's being updated on a daily basis, and it's a really, really good resource for that. Some of you wondering about the furry little thing on the left. That's Rosie 2. Rosie 1 died. We actually rescued her. She's a rescue spider. She's in our Poison Center. She is non-venomous. She is a Chilean rosehair. They're kind of the golden retrievers in the tarantula world. So if you want a pet as a spider, you want a Chilean rosehair. They're the nicest ones. They don't bite generally. They just tickle when they crawl up you. If you ever come to Hennepin County Medical Center and want to visit the Poison Center, you can come and see Rosie, and we'd be happy to show her to you. So my email is down at the bottom. Please feel free to email me with questions. We greatly appreciate that. Hopefully this has been beneficial to you, and I do have some time to go ahead and answer some questions here. So let me go ahead and, oh, I see that there's a comment about surprising because Mayo is in Olmsted. Yeah, I see that. So we appreciate all the great comments. If you have a question, please go ahead and go up to the question and answer. I'd be happy to answer them. We have a few minutes left here, and I'm willing to stay as long as necessary. And so I hope this is great. And thank you so much to the Minnesota Farm Bureau for allowing us to partner with them and bring to light maybe some more education from our side of things. So anybody out there with any questions? Not seeing any. All right. Well, thanks so much. I hope you guys have a great week. And if you got, like I said, if you ever just have a question, just go ahead and give us a call. I got a comment here that from a veteran point of view, the VA has gotten a lot better, and over the last 2 years, they prescribe opioids very heavily. I can tell you with friends that have been over there and combat wounded that yes, they do. I mean, that's kind of the answer. I can share one of my good friends was actually over in Afghanistan and took an AK round through the side. He was over there with a kind of a special forces role. The pararescue, the PJs came and got him, and he doesn't remember much about it other than they gave him this little lollipop. That lollipop was a fentanyl lollipop, which is used extensive in the military out in the field. He sucked on it. They tried to take it away, and he remembers telling him that he would effing kill them if they took away his lollipop. So it's a very, very effective way, but unfortunately, or fortunately, the VA is getting more savvy to that and hopefully doing better prescribing. Going cold turkey is a way to get off of things. You will not generally die from it. There's a question or a comment about that. It's not pleasant. I would encourage you to try and get into a program. That Opioid Dashboard for the MDH can help you with that. But cold turkey will work, and it's just not pleasant. So as far as farmers and ranchers, how can we do our part to make sure our local EMS are informed about opioid crisis and what's available to them from poison control and other state agencies? Well, I believe this is going to be archived. They can watch this. They can contact me at that email down below. I'd be happy to go ahead. I do travel throughout the state and do live seminars for police, fire, and EMS. I will be going to Cook, Minnesota here next month. I'll be going up to Wadena here next week. So just have your local police, fire, and EMS contact me, and we can see what we can arrange. And that's about all the comments at this point. Great comments, great questions. And there again, these are all things that we can answer for you if you call our poison helpline. 2 questions in Q&A. Let's see what those are. There we go. Do you want anonymous? What impact has this had on farmers in Minnesota? Is there any program in place to help farming communities? All right. Well, I will answer that live. I don't know of any specific programs for farming communities. What I would do is encourage you to start at your community health service, which is available at where your county community health services are, and inquire there. If you're not, and I know some have better ones than others, but you can look at that opioid through the MDH. Google that MDH opioid dashboard, and there is a section there that will kind of tell you what type of programs are out there and how to hook you up with people that have a better knowledge in your specific area and what programs to get to. So that's the best answer I have for you at this point in time. Do you want to review bags that decompose opioids? All right. So there are some things that you can buy from your pharmacy or be given through your pharmacy that you can put your medication in. It's basically activated charcoal, and then you can throw it away. The old school way is you basically could go ahead and take your opioids, you crush them up, you put them in with old eggshells that are nasty and old used coffee grounds, double zip them and throw them in the garbage. Now, I do know it goes into the landfill. At this point in time, there isn't a good way to reliably get rid of things that is environmentally safe. So that's what I have as far as bags that decompose. They don't really decompose them, they neutralize them or make them so unattractive that you don't want to dig through those bags and use them. I think we're out of time. With that, once again, thank you so much. Thanks to Jody and Kristen and the Minnesota Farm Bureau for allowing us to go ahead and put this on. Have a great day, be safe, and thank you so much for what you guys do, providing us with food and all that kind of stuff. Thank you very much.